Great. So welcome, everyone. My name is Kathleen Hill, and I am the moderator for this session. We're delighted to have your participation today, and we really appreciate Dr. Derman's engagement and leadership in leading this critical session. As you know by now, having gone to all of these different Zoom links, I'll do a brief introduction, and then Dr. Derman will be presenting, and then we have reserved time at the end for question and answer. We encourage you during the presentation to share any questions that you may have, which we will then discuss with Dr. Derman at the end of his presentation. We also may have time to open up for some spontaneous discussion if time allows. We'll have to see how it goes. So I would like to begin by introducing Dr. Derman, who, as you can see from the first slide, is Professor of Obstetrics and Gynecology at Thomas Jefferson University in Philadelphia, Director of Global Health Research there as well. And I think you can read his full bio on the website, but I'll also point out that he serves as Principal Investigator for the Global Research Network for Women's and Children's Health and has overseen more than 20 research projects, as well as acting as principal investigator for a large multi-site trial in India on anemia in pregnancy, which he'll be sharing with us. So we're very privileged to have Dr. Derman with us today. Just to let you know, Dr. Derman, we have a wonderful combination. We have Elizabeth Abu Haidar, Gaudiosa Tibaijuka, Jane Wausi, Jeff Jacobs, Jeffrey Smith, Jill Duraker, Joseph Misenga, Lori, Michelle McIntosh, Mivumbi, Sally, and Tony Thomas, and apologies for any mispronunciations. So you have your audience, and I think you've all now been introduced. So welcome, and we'll now hand this to you.
Well, thank you very much, Kathleen. Thank you for the, that's to wake up everybody on the East Coast. And that's to go ahead and sort of stimulate everybody who is in Europe and Africa and in Asia as well. You know, this plain picture I've used on a few slides, on a few talks that I've given, and it's really to go ahead and point out the incongruity of what happens in the real world. Here's a situation, fortunately, we don't see much of this anymore. And the airline industry learned a lot. There used to be many of these planes going down. We rarely hear about it anymore, and we don't because of team training, simulation, and the fact that everybody can speak and be listened to as an equal member of the team. These are lessons that we've learned in the healthcare field, and there have been books written on this subject. And I just wanted to point out that if indeed this were to occur, how sad it would be. And we would lose 300 or 400 people. And all of that would be in the headlines of the newspapers all around the world for the next week. But let's go to the next slide. Why don't we have the headlines reading the fact that we have over 800 women who die in childbirth every day, twice the number that die in a jumbo jet? Why don't we have headlines talking about the almost 300,000 maternal deaths every year? This is really the sort of incongruities that we address in the public health field. And since I do so much of my work in India, I'm going to, and our work in anemia is going to focus on India. It's important to point out that about 20% of all of that maternal mortality occurs in that country. Next slide. So why do women die? We know the answer to this. We know that even with the changes that all of us have been working on in the years that collaborations have occurred with our partners in underdeveloped, less developed, under-resourced countries, that 3 causes of death still sort of are there. And severe bleeding leads, as you heard from other talks the other day, maybe down from 35 to 30%, but it's still the #1 cause of maternal mortality. Preeclampsia and infection are probably about equal, especially if we include unsafe abortion. So our focus today is going to be the confounders, especially the role of underlying anemia in causing maternal mortality and bad outcomes. We shouldn't negate the importance of malaria, HIV, AIDS, and TB as confounders as well. And so I'll try to address some of this as we move forward. Next slide. So we know that anemia is the major contributor of I'm just going to go ahead and get rid of my picture so I can see the screen, is the major contributor or sole cause of maternal deaths in about 20 to 80% of maternal deaths. Direct cause in 20%, this has been proven, and up to 80% in the most recent data that's come out of India and WHO. If we look globally, there's about 42% of all pregnant women that are anemic in pregnancy. And of course, in some areas of sub-Saharan Africa, and especially South Asia, it's much higher than that, and I'll point that out as we move forward. Its frequency is 100 times more prevalent than cancer, and almost 9% of all of the total disability from all health conditions worldwide. It's an important issue. Next slide. So we know that iron is the most important micronutrient. For those in the nutrition field, they can point to differences in B12 and in folate and in zinc, copper, many of the other micronutrients, overall nutrition. These are all important. We're going to focus today on iron deficiency anemia, and we have to recognize that iron is involved in the physiology and functioning of every cell and organ in the body. We couldn't live without sufficient iron. We need it for iron transport, for erythropoiesis, for energy production, for DNA synthesis, and for cell proliferation and growth. Next slide, please. So this intergenerational effect slide I've used for some time now. I think it's really an important slide. So it's not uncommon for babies to be born iron deficiency and to be born stunting. To be born stunted, it's a major reason for stunting, actually, in terms of overall nutritional deficiency in iron. These babies may have reduced mental capacity. They may sustain frequent infections, inadequate growth. Then if they're women, they may go through menarche and begin menstruating and lose more hemoglobin, have more blood loss, and they enter pregnancy with almost no iron stores. This is not an uncommon situation. They become pregnant, lose more blood, and the circle continues on and on. So how are we going to go ahead and address this really important intergenerational effect? Next slide. So in India, as I said, the rates of this condition well exceed 50%. And that represents, because India is such a large country, the largest number of cases of anemia worldwide. And I will point out that much of the populace having moderate and severe anemia, especially in non-malaria endemic areas, live on plant-based diets. And in India, I know it's been a 40-year history. In other countries, maybe a little less, but a 40-year history of proactive government intervention. And we've seen little change in anemia rates, especially in the area of pregnant women and female adolescents. Next slide. So let's go ahead and focus on the maternal impact of iron deficiency anemia. Most, but not all of the published studies really, and many of these are small studies, many of them out of Europe, the United States, Australia, Japan, but many have shown that if you go ahead and diagnose in the first trimester, this is most closely correlated with an adverse pregnancy outcome, both for mothers and baby. It increases mortality rates, PPH, and preterm delivery. We know that anemic women have weakened immunity. I mean, we can measure CD4, CDH ratios, any one of a number of modalities, and this has all been published work. There's good work to show reduced work capacity and certainly reductions in life quality. And very, very important, the more significant the anemia, especially severe and moderate anemia, the more likely is the potential for a poor clinical outcome. And we see that in both the mother and in the baby. Next slide. So for the vantage point of this discussion, we'll use the WHO definitions of anemia, fairly similar to CDC definitions. And I want to point out that severe anemia of under 7 grams per deciliter, while very important in terms of bad outcomes, is fairly uncommon worldwide. In India, the prevalence rate is probably under 1%. And the only exception may be Pakistan, where we've seen rates approaching 7%. But moderate anemia is where the action is, and that's where we're going to focus our trial in. And we'll say a word about mild anemia as we go forward. So we also know, let's go to the next slide. So when we began to develop a protocol, we went back to the Global Research Network for Women and Children's Research. Thank you for pointing out that I've been a PI, one of 8 actually, in this network over the last 20 years. And we keep a registry, and a lot of that data is available to you all on the NIH website, so you can download that. But we had pretty good data out of Pakistan and 2 sites in India, and we were able to go ahead and determine a few things in sort of formulating our concept for the protocol. We saw that the rates of anemia in these 3 population bases was 87.8%. And we have seen recent publications coming out of Northeast India with rates of 85 to 90% of anemia, and in Assam with 90% reported. So not inconsistent with what we're seeing. We also saw that the adverse maternal, fetal, and neonatal outcomes were noted in cases of severe and moderate anemia, but we didn't find that with mild anemia. And we saw the same kind of situation with low birth weight and very low birth weight in women with severe and moderate anemia, but again, not in women with mild anemia. Hence the reason for the focus on moderate anemia, because with severe anemia, many governments already have very standardized protocols in place for addressing this small subset of women. So we ended our paper calling for a large randomized control trial where we can diagnose anemia early in pregnancy and where we can intervene as early as it's safe to give iron in the early 2nd trimester. Next slide, please. So I want to sort of review this section with you in terms of the lower the hemoglobin, the worse the pregnancy outcomes for mothers. In mothers, we see an increase in postpartum hemorrhage, an increase in cesarean sections, an increase in sepsis, an increase in preterm births, which we know is the leading cause of under 5 mortality. We see an increase in low birth weight in the baby and stillbirths. Really important data in terms of diminished cognitive performance and physical growth and stunting, and an increase in behavioral deficits. So this is really the compilation of the literature to date. Next slide. We also know that iron demands in pregnancy are significantly increased, not in the 1st trimester when women don't need as much iron and they're not menstruating, but it rapidly goes up to the increased necessity of 1 gram of iron in the 2nd and 3rd trimester. And this is because of the increase in fluid volume that we see, but most importantly to support the growing fetus, the amount of iron that's maintained in the placenta, and how much iron in terms of blood loss at the time of delivery that we may need to maintain. A lot of questions in the last session about serum ferritin. WHO has indicated that this is an important thing to measure along with hemoglobin, and we're going to be doing this in our trial. It's one way to make certain that we give people who have anemia that we're able to diagnose the cause of the anemia as being iron deficiency. You know that ferritin is an iron storage protein. It's probably the best indicator. We're going to use TSAT as well to even to be even more precise as to who should be getting IV iron. But the measurement of hemoglobin alone is probably insufficient to determine who will benefit from supplemental iron. And this is important, and there are a couple of papers now that look at serum ferritin in women. The work by Betsy Lozoff, especially Michael Georgiev, who's one of our co-investigators in this group, has reported that ferritin of under 15 micrograms per liter will adequately predict diminution of iron to the fetal brain, and this is probably irreversible. So we need to really intervene fairly early in the game. Next slide. So, you know, everybody knows that oral iron can work if it's taken regularly and if the anemia is not really, really severe, especially as we move forward in the pregnancy. So the problem is that the side effects are really significant. The adherence is poor. The absorption is bad. The latest data out of India shows that only 27% of women take oral iron as they should. And we're still grappling with how much oral iron to give. We've reduced in India from 100 milligrams to 60 milligrams of elemental iron. The recommendation is to do it twice a day if one is anemic. That's our population. And more recent data out of Zimmerman and others have suggested that every other day oral iron, in fact, may be better because of the impact of hepcidin. So let's move forward. So this is the latest recommendations from the British Blood Transfusion Society recommended, and we're all very cognizant of the guidances and recommendations that are coming forth, and they point out that intravenous iron should be considered in every woman with severe iron deficiency anemia. First-line treatment if hemoglobin is under 8, others, or any newly diagnosed anemia beyond 34 weeks of pregnancy. You cannot catch up. In fact, if you're in the second trimester under 9.5 milligrams per deciliter of hemoglobin, all of the oral iron that you take will not allow you to have sufficient iron to catch up. And we know from the work out of China and other places that if you have a hemoglobin of under 10 milligrams per deciliter, you're likely not able to transfer enough iron to the baby's brain, even if you show some response to the oral iron. And of course, anybody who doesn't respond to oral iron, meaning a 1 gram per deciliter increase in anywhere from 2 to 8 weeks, or intolerant to oral iron, need to be placed on IV iron. Next slide. So we're going to suggest a new approach. After all of these 40 years, it's time. We know iron sucrose has been available on the market in India for some time. It hasn't been used very well. The way it's been used, most people get half the dose or a third of the dose. They get it for 2 or 3 times instead of 5 times. It isn't surprising that the most recent data shows that it doesn't work very well. Well, if you're not using a drug according to the labeling, you won't get an impact. But now we're talking about single dose of IV iron. There are 4 formulations that have been approved in the United States and in Europe, 2 in India, and those are the 2 that we're going to be using in our study. We've seen no major serious adverse events. The package insert hints at 1 per million or a few per million, but we haven't seen those written up in any published study. And we really need to do a large study in those countries, especially places like India, where rates of moderate or severe anemia are the highest, where it's endemic. So in the rapid iron trial, this is a 3-arm trial. 2 of the arms use the 2 approved IV iron formulations in India, and 1 is the use based on Ministry of Health guidelines of oral iron. We're going to look at the outcome of great interest to the government of India, the rates of conversion to a non-anemic state at the time of delivery. That's part of their Sustainable Development Goal strategy to reduce anemia by 3% a year, whether a woman is pregnant or non-pregnant. We're going to look at the very important clinical outcome of low birth weight, under 2,500 grams, and of course, very low birth weight, because that's when iron gets absorbed to the baby. So that's a double whammy. We're gonna recruit and randomize over 4,300 women. And obviously, when we take a look at low birth weight, it's really a composite outcome of preterm birth and small for gestational age as well. Next slide. We have a lot of secondary outcomes, about 15 of them, and time doesn't permit me to go through all of them, but I've sort of listed 5 that really relate to our topic today of postpartum hemorrhage to this community of providers. The secondary outcomes include the rate of individuals who fall below 7 grams per deciliter at any time during the study, and they need a full workup and they require rescue therapy, whatever the hematologists and specialists feel are appropriate to be giving them. The rate of non-responders, this is important because this is written right into the new Mukh-Bharat recommendations from the government of India. So we're going to measure 8 weeks out whether or not those who've gotten any iron formulation, but we think it's more relevant to oral iron, did not have at least 1 gram per hemoglobin increase at that 8 weeks. And those 2 will also be referred, but will remain in the study. We're going to measure the rates of PPH, the rates of cesarean delivery, and very importantly, at 6 weeks postpartum, differences. We're going to look at breastfeeding rates and other things, but we're going to look at really validated differences in quality of life indicators. Next slide. So I want to present a challenge to us all from a public health perspective, recognizing that every 4 or 5 minutes a woman dies from postpartum hemorrhage. And so we would not deny the fact that this is a public health imperative to address this issue. And I think this meeting is really one important component of how we do it. Next slide. Next slide, please. And to bring it home even further, we recognize that the average interval to a woman's death with bleeding really is focused on postpartum hemorrhage. That if you have a ruptured uterus, you often have sufficient time to get women to a higher level of care. That may be true with an antepartum hemorrhage as well. But in postpartum hemorrhage, where the spigot opens up, and we know this from our work with misoprostol, we often have only 2 hours. And there the whole concept of resiliency kicks in. Resiliency, in this case, in large measure, is based upon how much oxygen carrying capacity a woman has based on her hemoglobin level. Next slide. So in terms of public health strategic directions, it's certainly far better, and we've shown that it's generally less costly to prevent a condition rather than to treat it, and this is true with postpartum hemorrhage. We think it's important to show that a single infusion of IV iron given to women with iron deficiency anemia is proven to be impactful. And as we heard from Jeff the other day and others, we need to build in a cost effectiveness analysis in every trial with new drugs, and we've done this in our study as well, because this is going to help inform implementation and scale up. Next slide. So I want to end really my next to last slide, which is really a quote that I'm not sure I wrote it or somebody else wrote it, but the best predictor of pregnancy outcome is the state of health of a woman when she first enters pregnancy. I think we all recognize this, the importance of addressing iron deficiency anemia before pregnancy is certainly a goal, but let's go ahead and do this if we cannot get women then at the earliest stages that we possibly can. And finally, the last slide, I do want to thank the Children's Investment Fund Foundation for thinking that our concept was good and supporting this very, very important work. A number of you sit on our technical advisory group, and I want to thank you for offering support as well, and for all of the other funders who've given credence to our research over the years. Thank you very much.
Thank you very much, Dr. Derman, for that very stimulating presentation on such an important topic. So we now have about 5 minutes for questions. We have a question that's come in, and the first one that came in was, is there any additional benefit doing a hemoglobin test to pregnant women on a monthly basis compared to doing it once in each trimester during ANC? So a question about frequency of testing.
Probably not. And I know that that's sort of shooting from the hip, but we're going to be doing it based upon Ministry of Health guidelines. So we're not asking women, we're not asking to change the system of when they appear to go ahead and get their hemoglobin tested. So we think that getting 6 values is probably important. The very important cord blood that we're going to be getting at the time of delivery is critical. We're going to go ahead and see what those values are. We're going to biobank the rest of the specimen for future research, looking at growth and development in the babies. But I think that actually getting women to antepartum care early, getting them in to support that WHO frequency that the Ministry of Health of India has picked up on is probably a very reasonable thing to do. The closer one gets to delivery, the less important the other modalities other than hemoglobin are. And so we're not going to measure those except in cord blood and 6 weeks postpartum.
Thank you very much for that response. We have another question from Jeff Smith, which is, what do you believe is the mechanism of action for PPH among women with moderate to severe anemia?
Well, I think it's a confounder, and that was the reason for the title of this slide. So many of these women are in the lowest socioeconomic group. They already are hard-pressed when they enter pregnancy. Their resiliency because of poor nutrition, because of diets already compromised. There may be a genetic component to this, I don't know. But you know, when we talk about intergenerational effects of anemia, we probably ought to do similar work in looking at who from families actually sustain postpartum hemorrhage. I don't know that I've read that work that really would be important. And as I said in the prior group, well, we don't have this built in because our study is being done in primary health centers and community health centers. A hospital-based study to look at near misses in this population may help answer some of the questions, Jeff, that you bring forward. And I think that Jirka hinted at yesterday or 2 days ago.
Thank you very much, Dr. Derman. I've often wondered the same thing, and very interesting to hear your reflection that it's likely a confounder. Jeff, if you have any follow-up thoughts, please feel free to put them in the chat. I'm sorry that we're not able to unmute you. It would have been nice to be able to have a discussion, but because of the mechanism, we have to use the chat or the Q&A box. So I'd like to invite any other participants. We have about 2 more minutes. If there are any other questions that they have for Dr. Derman or any reflections, please feel free to share them in the Q&A or the chat box if you'd just like to directly share reflections. So this is a question from Jeff Jacobs for you, Dr. Derman. Can we assume that many of the results of the rapid iron trial will be transferable beyond India?
Well, it's a great question. It's a great question, Jeff, and I hope we have a chance again to meet in person and have dinner together and talk about that. We had a question in the last panel that I did about malaria and the impact of malaria in sub-Saharan Africa on giving IV iron. I think the Gates Foundation is halfway through or so with a study in Malawi looking, and I think one of the areas they'll be looking at is particularly this arena. So will this be scalable all around the world? And we think that the latest data would suggest that if you treat malaria, that you probably do get a positive benefit with use of IV iron. So I'm sort of going out on a limb and saying I do think it will be important and scalable. There'll be many lessons learned, and those lessons will go beyond maternal health. They will really, we already have a commitment to look at how these babies are doing up to 3 years of age. And we know that there are 4 papers in the literature now, Jeff, that links autism spectrum disorders to iron deficiency. How important and what a major breakthrough this would be if we could show that correlation.
Wow. Yeah. Thank you for that that response and for bringing out the malaria piece as well. And I think it's really a call for all of us to be aggressively promoting, intermittent preventive therapy for malaria during pregnancy, which we know still has very low coverage, as part of addressing this profoundly important anemia issue. So Jeff has just shared back a reflection, and I'm sorry, Jeff, that you can't say this out loud, but he writes that my hypothesis has been that the uterus, like other muscles, fatigues in a low oxygen environment, such as in the case of severe or moderate anemia, resulting in the PPH.
So let me just respond to that. You're probably right, because as I said in one of my slides, anemia affects every cell, but we now know with early placentation that in anemic women, you get fibrosis, and you also end up with changes in the terminal villi that do not allow the appropriate exchange of oxygen to occur. So that's another mechanism for looking at the outcomes and the reason why we need to intervene as early as we possibly can.
Thank you, Dr. Durman. Jeff had a final, just really a sharing comment that there's an IV iron trial in Malawi and one starting in Bangladesh and potentially one in Nigeria. So it sounds like we'll be getting a lot more data along with your study, which is very exciting.
It's really great. And you know, we are happy. We will publish our protocol as soon as we possibly can. But if indeed those protocols are available for sharing where it's not pre-publication, it would be great for those of us working in the field to take a look at this and see what we're missing, what we're able to address collectively and otherwise. So I'll throw that challenge out to you, Jeff, because I think that's really important.
Great, thank you so much. Yes, lots of fertile ground for important collaboration in this area. Coming back to Jeff Jacobs' question about what can be transferable, what can we learn across multiple contexts. So I want to thank you, Dr. Durman, very much for your very stimulating presentation, for your leadership, your continued prioritization of this critical issue that, as you say, has been really shamefully neglected over many decades, and that has such impact for women and for their newborns and for their children. You know, as you said, cognitive deficits are a major result of iron deficiency. So I want to thank all of our participants for the interest, for the commitment to this issue. We are now going to transition back to the plenary session. You'll see in the chat box the link that has been posted, and I think by now we're all fairly expert. Just go to day 3, the plenary session, and we'll rejoin you there. And many, many thanks, Dr. Durman.
Thank you, Kathleen, for facilitating the meeting.
It's been a pleasure. Thank you. Bye-bye.
Bye.